Good afternoon and welcome. I'm Jeffrey Cleaver, the Executive Director of the Business Healthcare Group. And I'm very glad all of you could join us, whether in person or virtually. We are pleased to present the results of the second Physician Value Study commissioned by BHCG and completed by GNS Healthcare. I'd like to acknowledge and thank the Greater Milwaukee Business Foundation on Health for their continued support of this critical project. They were also a major supporter of the first Physician Value Study, so once again, a great deal of gratitude to the foundation. So a top priority of BHCG in the Wisconsin business community is to purchase high-value health care. All stakeholders benefit when we increase the value of health care: employers, employees, and their families and the community in which they're located. We all have a vested interest in helping to make Wisconsin a great place to do business. The Business Healthcare Group has been and remains committed to being a good corporate citizen for all of the state of Wisconsin. And you'll see what I mean by that as we talk about the study. To that end, in 2019 and 2021, BHCG commissioned GNS Healthcare, a leading provider of artificial intelligence applications in healthcare, to complete the physician value studies. The studies are designed to evaluate the value of care delivered by physicians throughout Wisconsin using claims data from the state's all-payer claims database, WIO, the Wisconsin Health Information Organization. And many of you who are familiar with the Business Healthcare Group know that currently the geographic footprint for BHCG is in eastern Wisconsin, but the results of the study apply to the whole state of Wisconsin. And once again, we're trying to support not only eastern Wisconsin, but the full state of Wisconsin. Our goals in commissioning both studies are to support health system performance improvement, once again, to support health system performance improvement, and inform employer benefit design to support better healthcare decision-making through the steerage of patients to higher value providers. The results of both the first and second physician value study reveal the potential for substantial cost savings through improved physician performance. And Dr. Earl Steinberg is going to go into detail on the potential savings associated with improved physician performance. And many of you are aware that Business Healthcare Group moved forward with Centivo in the implementation of a high-performance health plan with a primary care provider-centric model, and that is effective for 1/1 of 2022. So that high-performance health plan solution represents the continuation of BHCG's mission-driven journey to once again increase healthcare value by working directly with health systems and provider groups. And BHCG embarked on that journey to work directly with health systems and provider groups approximately 4 years ago, actually when I moved into this position. And what we made the decision to do was to take the medical health plan out from between BHCG, and it's critically important that everyone understand the business community. So it's not just BHCG, but it's also the business community, to move forward and drive a collaborative dialogue with health system representatives and provider group representatives to create a plan that aligns with our objectives, including accountability. And then this next objective is why we selected Symposium as our health plan partner, and that's to reward value and not volume. The GNS physician value study data was used as the foundation for BHCG and Symposium to develop, once again, Wisconsin's first high-performance primary care-driven health plan option. We are extremely fortunate to have WIO, GNS Healthcare, and Symposium laying the foundation for our efforts to positively impact the cost of healthcare value in the state. And once again, I'm sure you will find the latest physician value study results quite compelling. So there is going to be a question and answer session after Dana finishes her second part of the presentation. And for those of you that are participating virtually, in the bottom toolbar on your screen, there's a Q&A link for you to provide your questions. And we have received a lot of questions in the other sessions that we've had today. So we started off the first meeting this morning with employers and other stakeholders. The second meeting this afternoon was with health system and provider group representatives. We're now with you, the broker and consultant community, trusted advisors to our member employers and your clients. And then tomorrow we go to the state capital to meet with legislators. So the agenda for today, my opening remarks, I then transition to Dana Richardson, the Chief Executive Officer of WIO, who is going to provide an overview of the Wisconsin Health Information Organization and talk about data. And then Dana will transition to the physician value study methodology and results with Dr. Earl Steinberg, and we are incredibly fortunate to have as a resource Dr. Steinberg and GNS. And Dr. Steinberg is an Executive Vice President of Payer Market Access, Hero Lines of Business with GNS Healthcare, and he will go into more detail on his background, which is incredibly impressive. And then we move to the Symposium GNS Healthcare Value Proposition. Dave Ostendorf, who has been the strategic consultant for the Business Healthcare Group for a number of years, and Dave is also the chief actuary of Symposium. We will then go back to Dana, and Dana is going to talk about several new products that have been developed, including a product that is going to be that has been built to operationalize the results from the GNS study. So with that, I'll turn the presentation over to Dana.
Well, thank you, Jeff, and thank you all for the opportunity to talk to you today about the Wisconsin Health Information Organization. For those of you who are not familiar with WIO, our mission is to create more health data and information to advance actions in support of our vision, better health, healthcare, and healthcare value gained through objective information. To fulfill this mission and vision, we provide both data as well as information to all healthcare stakeholders that are interested in improving the health of Wisconsinites, as well as the health outcomes of the healthcare delivery system. The data is used for a variety of purposes, for strategic and policy development, for public health evaluation, for research, and for other opportunities, and in this instance, for this study, for cost and quality evaluation. My goal today is to provide you with a framework that you can use in order to evaluate the information that we're giving you today about the study, as well as the reports that I'm going to talk about at the end of this presentation. But before I do that, I want to talk for just a minute about another project that I was involved with some years ago. I had a very good friend who wanted to create a hot rod out of a 1957 Chevy that he had owned and had in storage for 25 years. So the raw materials for this project were really the 1957 Chevy. However, in order to get to a hot rod, a lot of work had to be done. So tools were required. And you can see on the top of my slide here that the mechanics shed that we used had lots and lots of tools, but we also needed people. We needed people with the expertise to do this work. All told, there were 4 people who worked on this project pretty intensely, and then a variety of other people that came in to help us solve specific problems. This project was a complete frame-off restoration, which meant the entire car was taken apart down to the very last nut and bolt. And then systematically, we had to determine, should we keep a part, should we refurbish a part, or does it need to be replaced? So in the middle of this slide, in the lower left corner, you can see the basic frame of the car. So we took the whole thing apart. And on the top of the middle section, you can see the engine, which we decided needed to be refurbished. And it needed to be refurbished so that the car would go faster and the car would be much louder in the end. We went through this process with multiple parts, refurbishing them, making them a little bit better than they were before, and definitely making sure that everything was safe. The other slide in the middle section is an example of replacement. So the entire electrical system was replaced in this car. Once we'd gone through this entire process with every part of the car, we then started to put it back together. And so the lower section of this slide, you can see that the engine is going back in. And then, of course, on top of that, we took the rebuilt carburetor and we put that on, and then the filters on top of that. And because the engine was too hot, we had to actually create a fan system to cool the engine down when it was running. So that was a new additional piece that we added to it. We also had taken the whole car down to the bare metal and taken out any rusted pieces and put in new sheet metal. And then what you see here is once that had all been sanded down and primed. And then finally, the last step of putting the car together after it was painted was putting in a brand new interior that we, some of it was new, some of it we took from refurbished parts so we could have bucket seats and all these fancy things. In the end, what my friend ended up with was a beautiful hot rod. He's won lots of awards with his project. But I think the most important thing about this project was that weather bearing, he drives this car every single day. He uses it. So all of this work was worth it. What people see is the car. But in order to get to that point, all of these other things had to happen. So building a report or the results of this study is very similar to building a hot rod from my perspective. Because it takes, what you see is you see the results and you see information in a report. But in order to get there, you actually have to go through a series of steps and a series of refurbishings and analytical processes in order to get to that final report. So everybody knows that there's no such thing as a perfect data set. In my opinion, there's no such thing as a good or a bad data set. The principle that I like to think about is the data that's being used for a particular project, is it fit for the purpose for which the project was put together? So that's the intended use. What do you want to do with the information? What questions are you asking of the information? That's the first thing you need to understand. The data then becomes really the raw materials. The raw materials that come in to the project in order to make the project successful. With the WEO data, we also use a lot of groupers in order to add additional information, like the fan in my friend's project. And then there's going to be a system of measurements, analytics, testing of the results that has to occur, and finally, a lot of detail goes into putting together the final report format and the delivery system. So I'm going to talk today about the data and the groupers first, and I've put together a list of questions that I think are important for you as people who would be potentially receiving or using this information to think about. So the first is, what is the source of the data? So WEO data is provided to WEO by health plans, by self-funded employers, and by the Division of Medicaid for the state of Wisconsin. What we actually receive is fully adjudicated claims. And I think that that's an important point because in the adjudication process, the claims are checked to make sure that the right codes are put on the claim and the right prices are put on the claim that make sense for the service that was actually delivered. But it's also, once the claim has been paid, it's really an agreement between the provider and the payer that all the information is accurate. Second thing I would ask is, does the data have a representative sample of whatever it is you're going to measure? So WEO data covers all geographies of the state. We have about 75% of the population, or about 5 million people in our database. So certainly a pretty good representative sample of the care that is provided here in Wisconsin. It does include all providers, all sites of service, all different diagnoses, both medical and pharmacy claims, et cetera, so pretty comprehensive. I think one of the interesting things, though, about using claims data, which has been used for evaluation for over 30 years, is that it's really based on nationally standardized ontologies, or what we would call claim sets. So these various data sets are updated annually. There is training that goes along with how to use them. There's also auditing to make sure that they're being used properly, particularly done by the payers. So the data is really scrutinized, it's highly standardized, doesn't mean it's 100% accurate, but it's going to be about as accurate as you can get. The other thing that I would be asking is, what kind of quality checks are done on this data? So when the data comes into WEO from the different data contributors that provide the information, we actually check it at multiple stages in the process. So we have both automated as well as humans who actually look at the data to make sure that the data that's coming in is the data that we expect to be coming in. We do that when the data is first submitted and reports are provided back to the data submitters so that they can make sure that the data coming out of their claim systems is appropriate. But we also do it every single time we create a database. So there's a lot of quality checking that goes into our processes. The last thing I'm going to talk about right now is the groupers that we use, because groupers are actually a way that you can create additional data. So the database that was used for this particular study is our enhanced database, which we refer to as ED. The enhanced database includes all of the claim level data for a 2-year period of time frame, but it also then includes data that we create using these groupers, and that created data is very helpful with the analytics. So the first software system that we use to do this is called the Episode Treatment Group. An ETG is similar to a bundle of care. It has a beginning point and an ending point, and then it collects and tags at the claim line level every inpatient, outpatient, ancillary service, pharmaceutical that belongs to that episode of care. In doing that, you can kind of look at the whole complete bundle of care that is being provided by using these episode tags. The second software system that we use is called the it's called the Episode Risk Grouper. And the Episode Risk Grouper is what helps us to look at risk and predict the risk of various patients. And we know in healthcare that not all of the people that come into a hospital or a clinic are the same, right? People come with different comorbidities, they come with different backgrounds, different ages, et cetera. And so by adding risk assessment to the data, it allows us to then stratify the results of any analytics that's done with this data system into different risk categories. The third software system that we use is normalized price. So normalized price is a little bit tricky, but what normalized price actually does is it applies the same price to every service that is provided. So if a chest x-ray is done at provider organization A and a chest x-ray at provider organization B, the same dollar amount is applied to both of those chest x-rays. Now, why would we do that? Well, what that does is it actually eliminates differences in geography, it eliminates differences in contractual relationships as well. And you can then look at how many resources are actually used to create the same output within an episode. So if provider organization A does 2 chest x-rays and provider organization B does 3 x-rays, it's a lot easier to identify that if we eliminate the variation in price. For this particular study, we also used a fourth software that's not typically one that we use, but it's called evidence-based measures. The evidence-based measures software puts an indicator on each claim stating that it belongs to one of the 700 plus measures in the software system. These measures are sourced and follow the specifications of measures that are used by CMS, that are used by NCQA in their HEDIS evaluation. They're brought in from the Pharmacy Quality Alliance and other organizations that have spent a lot of time both developing these measures but testing them for accuracy as well. So with that, I'm going to turn it over to Dr. Steinberg, who's going to talk about the actual analytics, the measures that were used in this report, how the results and the data were tested, and then finally also give you the results.
Thank you, Dana, and good afternoon. Before I get started presenting an overview of what we did in this study and what we found, I thought I'd start off by just providing some insight into my background as it's relevant to this study. I've spent 35 years analyzing insurance claims data, including doing so for insurance companies. I'm a general internist. I was a professor of medicine at Johns Hopkins for 12 years and have been an adjunct professor for many more. I've worked in various provider settings, primarily the Geisinger Health System and Johns Hopkins. And I've also worked on the health plan side as the Senior Vice President of Clinical Strategy Quality at Anthem. What I'm going to be presenting today is the following. I'm going to be talking about the quality and efficiency of individual primary care physicians, looking, as Dana said, at 2 years of data, in this case 2018 and 2019 combined, what the cost efficiency is of individual specialists when performing certain procedures, looking again at the same data, and finally estimating the potential cost savings that would occur if patients were either incented to see higher efficiency physicians, and both PCPs and specialists, or improving the performance of lower PCPs and specialists. While Dana talked about some of the advantages of using normalized cost data, one of the disadvantages from this cost efficiency perspective is that it washes out differences in the amounts actually paid to different providers. And as a result, our analysis is based on standardized prices, which really reflect the intensity of individual services. A little bit about aspects of the methodology. As you've heard, the data came from WIO. In order to be included in the analysis, patients had to have both medical and pharmacy benefits throughout both 2018 and 2019. Patients were attributed to physicians if they were assigned to a particular PCP in the data set, and if no assigned PCP was there, we attributed the physician to the PCP who was responsible for the majority of cost for that patient. The ETGs that Dana mentioned that we used were included in the analysis if they met several criteria. One, the episode had to have been completed in full. The episode had to have not been a cost outlier, as reflected in an outlier flag in the database. We required that there be at least 500 episodes of care across all PCPs for the ETG to be included in the analysis. And finally, we had to believe that a PCP could reasonably be held accountable for the cost of an episode in that ETG. An example of situations where we did not include an ETG for the latter reason are ones where surgery related to chronic disease occurred, and we did not think it was reasonable, looking only at 2 years of data, to assign or attribute responsibility for those costs to a PCP, because they wouldn't have necessarily been responsible for caring for the patient for a long enough period of time. As a result of the 700 ETGs that exist, we looked at only 151 that met these criteria. We also used 294 of these evidence-based measures that were related to the management of preventive care or diseases that are commonly managed by primary care physicians. The cost analysis is a bit more complicated, but I'll try to simplify it by running through this. First, let me mention that the quality scores, which you're probably familiar with, basically consist of a ratio of a numerator and a denominator. I actually think of these, it's analogous to a batting average, where the denominator is the number of at-bats, that a physician has, meaning the number of instances in which a particular evidence-based measure applied, and the numerator consists of the number of those instances in which the physician's care was consistent with what that evidence-based measure said should be done. So, for example, if a quality score was 0.8, that meant in 80% of the instances in which an EBM applied to an episode of care, that physician's care was consistent with what that EBM called for. We used the log of these normalized costs to look at costs in order to produce a typical bell-shaped curve. And we used our artificial intelligence platform to estimate the predicted cost for an episode. And in doing this, we controlled for every variable that we could think to control for. These included age, gender, line of business, specific comorbidities, number of comorbidities, complications, a comorbidity score. We also looked at that ERG measure that Dana talked about, and we found that it didn't add anything to the accuracy of our predictive model. And an overall cost efficiency score for an individual PCP was calculated by looking at the weighted average of the actual cost compared to the predicted cost for each episode of care, and the weight was the number of times that that particular type of episode occurred. And this is just to show you the comparison of the results with and without that ERG adjustment, and basically shows that there was no improvement in the predictive accuracy. In the case of looking at the cost efficiency for specialists, we looked at 9 procedures. These are the most frequently performed procedures and reflect care delivered by a number of different specialties. And as I mentioned, we estimated the potential cost savings that could be realized if all physicians practiced at a level that was at the 50th percentile of performance or better, using our AI platform, which I'll tell you about in a moment. So there are different types of artificial intelligence. The most commonly used is something called deep learning. Deep learning can identify statistical associations between 2 variables, but it cannot identify causal relationships between 2 variables. Our AI platform uses something called causal learning, which is used much less frequently. It was developed by a guy named Judea Pearl, who is a professor at UCLA. He won the Turing Award, which is basically the Nobel Prize for computer science, for the math that he used to develop causal learning. That same causal learning math was used by the 2 gentlemen that just recently received the Nobel Prize in economics. All of the math underlying this is published. So there isn't any question about transparency about it. All that GNS has done is take that math and put it on a software platform that was scalable so that we could analyze very large amounts of data. In addition to being able to identify causal relationships between two variables, causal learning also enables one to answer a series of what-if questions. For example, what if a particular patient had been treated with drug B instead of drug A? What would have happened? And this can be done if there's a large enough sample of data that includes requisite data elements. In this case, we used that component of causal learning to predict the amount of savings that would have occurred if all of the physicians we looked at had practiced at the 50th percentile or above. We added one additional requirement in order to include a PCP in our quality analysis, and that was that they had to, and our efficiency analysis, they had to have at least 30 episodes of care. And this was an attempt to try to increase the statistical stability of the point estimates around somebody's quality or efficiency. And we did something further that I'll talk about a bit later to try to further enhance the confidence that we have in the particular categories in which we classified docs. So out of the sample of all the PCPs in the state, we wound up including 4,587, which is about 20%, in our analysis. There were certain types of PCPs that we were instructed to exclude from the analysis. This included specialties like geriatrics, GYN, and as I said, had to have been the requisite number of ETGs and episodes of care. This slide shows the distribution of types of primary care docs that were included in the study. As you can see, a bit over half were family medicine physicians and about a quarter were internists, so about 16% were pediatricians. A bit over 800,000 members' experience was included in the analysis, and over 1.5 million episodes of care were examined. And the mean number of patients per PCP included in the analysis was 205, and the graph at right shows the overall distribution of number of patients per doc. The table at the bottom shows the distribution of patients by payer. As you can see, 45% of patients were insured by Medicaid. About a third were insured by commercial, and about 16% were insured by Medicare, and in 7% of instances, we couldn't confidently identify the insurer. This slide shows the results of the quality analysis. The 25th, 50th, and 75th percentile are shown here, as well as the overall distribution. And a score of, for example, 0.688 at the 50th percentile means that, as I said earlier, about 69% of the time a particular PCP did what the evidence-based measure said should be done. We then applied some additional criteria to put physicians into one of four categories. And here we required at least an 80% confidence that we were putting the physician in the right category. Now, we're used to 95% confidence in scientific studies, but if you required 95% confidence, there'd be almost nobody in the study because there wouldn't be enough observations. So we pushed it to the limit. We looked at other levels of confidence, but the docs in the lowest category, we were 80% confident that their performance was worse than the 50th percentile, and you can see the criteria that we used for these other three categories. Just to show you a bit more about the cost efficiency scoring, as I said, we used our software platform to adjust for differences in case mix, and using the log of the predicted cost over the actual cost, we obtained the distribution that you see in the graph. If a score was less than 0, that meant that a physician's predicted cost was less than the actual cost, and if the score was positive, greater than 0, it meant that the actual costs were less than the predicted cost. This side, again, this shows the cost efficiency rankings, and in this case, about 35% of physicians were in the fourth category, where we were 80% confident that their performance was worse than the 50th percentile. And this is just showing the number of patients and number of docs in each of these categories. And obviously, about half of the docs were in the below the 50th percentile, and the number of patients was similarly. This slide shows the scatter plot for the relationship between quality and cost efficiency. Cost efficiency is on the x-axis, axis, and quality is on the y-axis. And as you can see, there was no correlation between cost efficiency and quality. A similar finding has been reported in many other analyses of this type, and there were 1,083 PCPs who were better than the 50th percentile of cost and of quality. This slide shows our estimates of the amount of money that could be saved if all physicians practiced at particular levels of percentile performance. And as you can see, total spending was about $810 million per year for the ETGs that we looked at. And the annual potential savings, if everybody practiced above the 50th percentile, is about $325 million per year. Here again is the list of the specialty procedures that we looked at. And here's the number of episodes, number of providers, and the total cost for each of these types of procedures. Total spending on the 9 procedures was $681 million per year. And you can see the total amount for each of the individual types that was included. Finally, when you tally all that up, there was about $1.5 billion that was spent on the care provided by the PCPs and specialist procedures that we looked at. And in total, about a quarter of that amount, 382 million, we estimate could be saved if all of those physicians practiced at the 50th percentile or above. And you can see the breakdown of that by PCPs and specialist procedures. So finally, the conclusions I would draw are that, number one, there's substantial variation across PCPs in both quality and cost efficiency of care. This is not a surprise. There also was substantial variation across specialists in cost efficiency. We didn't look at their quality because we didn't think that the quality measures that were available were suitable and sufficiently robust to perform that analysis. More than $382 million we think could be saved per year. As I said, if everybody practiced at the 50th percentile or above. And that estimate would be even greater if we considered episodes that were below the 50th percentile for docs whose overall cost efficiency score was greater than the 50th percentile, and if we considered the appropriateness of care in our specialty analysis. In other words, we didn't look at whether all the procedures that were performed were clinically indicated because we weren't in a position to do that. So hopefully that provides you with insight into what we did and what we found, and I'll turn it over to Dave Ostendorf.
As Jeff noted, as Dave Ostendorf, I'm been the strategic advisor to the Business Healthcare Group for an awful lot of years, and I'm the chief actuary at Symposium. And so yes, I've let the cat out of the bag that I'm an actuary, which means both by reputation and by profession, I have to be a data geek. So a study like this is something that is going to be exceedingly interesting to me. I know that some of you have a bit of PTSD around your college statistics courses when we start getting into confidence intervals, but there's an awful lot of good information here. I will tell you that having done this kind of work for a number of decades now, this is one of the most sophisticated and robust studies I've seen, and I guess because I ran a practice of about 250 actuaries back in my old Parent Towers Watson consulting days. And given roles like my role on the Board of Actuaries for the U.S. Department of Defense, I've seen an awful lot of analysis and a lot of efforts to try to create this kind of information. This study is one of those that really is, I think, top tier. So a big piece of the whole conversation that goes into something like this, and a lot of what Dana and Earl have talked about, is the what of the study. What is the study telling us? What are the data points? What are the pieces of information that we can take out of it? And from that standpoint, it's all, I think, exceedingly interesting and information that can be very useful in discussion. But we need to go beyond the what, and frankly, into the so what. How are we going to take this information and put it into action? What do we really want to do with it in terms of changing healthcare to the better for, particularly for plan sponsors and for employees that are in plans that the employers are running these days? And so when the BHCG came to us from the Centivo side and said, we really do want to put in a new kind of program in eastern Wisconsin, the conversation was pretty straightforward in terms of the outlines. We've said we've got to have a solution that focuses on having an affordable option, an affordable opportunity, both from the standpoint of employers as the payer and their people. And obviously we've lived through a number of years now where substantial additional financial burden has been put on members within health insurance plans through new cost-sharing kind of approaches, and whether it's the high deductible structures or other kinds of changes. There's a lot of exposure that members have picked up. And as patients, they have at times done things inappropriate to their ultimate care because of some of the financial barriers, and we need to address that. There are things that we wanted to bring in relative to the quality position, and really looking at how do we move greater into higher quality care. There's the whole question of how can we change some of the payment models that say let's move away from payment for volume and move towards payment for value. And that is an evolutionary process and something that starts with some small steps and then continues forward. But we knew that needed to be part of it. Sentivo's role in all of this was to take that employer vision, take the vision of the Business Healthcare Group and their executive steering committee, really as representative of the business community in eastern Wisconsin, and move it forward into something that actually is an achievable solution that they can offer to their people. So Sentivo's role really is to be the conduit to that. The employers are asking us very directly to have a little closer connection to the provider community. And I will give Jeff and his executive steering committee credit for having really engaged in that dialogue well ahead of, frankly, both this study and in terms of creating the new product that we have created for the Business Healthcare Group. That dialogue has been important. I think the more that the employers can talk with the healthcare providers and vice versa, the better the understanding of each's needs, the better the ability to create significant alignment. You're going to hear a lot of conversation about just that. Alignment is critical to this solution. As we talk about the structure that BHCG asked us to put together on the Sentivo side, it really was predicated on these 4 elements. It was a conversation about how do we create stronger relationships between a patient and a primary care physician and, frankly, a primary care team. How do we create the ability to have someone have a guide through the system? How, frankly, do we get people to actually listen to their primary care physician? It's a reality that a physician can be performing at their absolute best, but if their patient isn't following the suggestions and recommendations, we're going to have a problem. So we need to look at what's necessary to create that kind of option. How do we align things like plan designs and underlying offerings that employers have to get people to really engage with and follow the direction of a high-performing primary care physician? That whole trade-off that goes in and says we as a employer group will deliver to the provider community a group of patients who are highly motivated to select and work with their primary care physician also comes along with an expectation of accountability of those primary care physicians to truly manage the total cost picture for the patient and to be a holistic patient manager. I think it's what an awful lot of primary care physicians went into the business to do, and it is something that we think is a valuable part of this. It is a necessary element and something that needs to be done in an effective way and have the accountability. And finally, the payment mechanism has to reflect that, so that at the end of the day, we know that we are asking the healthcare community as a whole to, frankly, receive less revenue as we spend less money on our healthcare programs. That has a basic business necessity that says if I'm getting revenue that is at a lower level, I need to find a way to maintain my financial viability. And really, can we take some of the success sharing of this kind of program, allocate some of it back to the provider community to keep them as financially viable as possible, while recognizing that the total spend has to go down. And that is clearly an element of this as well. What has that resulted in from the Sentivo perspective? It's resulted in a bit of a different kind of network. Because we are drawing those strong primary care physician relationships, because we are asking for accountability, because we are steering in a different way, it's important for us to work with systems that have engaged with those principles, that understand that basic construct, that really have some experience with the whole idea of how do I get value-based reimbursement in place, that look at this as an opportunity to create better care in a more managed way. Those are all necessary predicates. What we have done is gone in and said we need to connect our people to the high-performing PCPs. And that says that we're going to do things like use the information from the physician value study to create exactly that pool. Within a Symposium program, a member is asked at the very beginning of the plan year to select a primary care physician that they will work with. They are obviously presented with a group of high-performing primary care physicians relative to the study. What we did in terms of using the study results under the guidance of the Executive Steering Committee from the BHCG is said, let's first look at quality. And we are concerned, and when you saw the chart on the quality side, that there are a group of outliers where their EBM compliance rates are very low. And those weren't individuals that we felt comfortable connecting our people to be their guide to the system. We also took a look at the four-quadrant chart that Earl showed relative to cost efficiency and quality and said for those physicians who are in the lower half from a cost efficiency standpoint and the lower half from a quality standpoint, we again are uncomfortable with that group being the guides for our patients. Therefore, the remaining group, which constitutes about 3/4 of the PCPs in the marketplace, are available to Symposium members to select, as we would describe it in the Symposium role, to activate at the beginning of the plan year to get the relationship started to choose to be their guide for care. That's a group that is large enough to give our people very good access. It is a group that is substantial enough that we feel like we have a very comfortable position relative to geographic mix, relative to the different kinds of criteria that people would use to feel comfortable with their PCP. But it does also recognize that there is a group who has not met the bar. And we're going to talk about how we work over time to reduce the size of that second group. When we think about the criteria that go into this, what do we have to think about? From the employer side, and especially the BHCG member employers who historically have looked at tiering mechanisms and have been frustrated when those tiering mechanisms have a great deal of variability year over year. What we're really shooting for here is a significant level of, to have an imprecise term, stickiness. If you're a high-performing physician in year one, we expect you to be a high-performing physician in year two and year three. Part of the problem with other evaluation systems that have been used is, frankly, the data set is either too small or too inconsistent. And so we get a lot of statistical noise in the evaluation model. And that's the last thing we need. The physician value study uses, because it has the WEO data set, because it has as large a data set as possible, because we put the confidence interval criteria around it, because we have done the analysis in a way that really is as robust as it is, we expect that that noise that comes from the statistical process will be eliminated. And therefore, we won't get that kind of variation. So we expect high-performing physicians to stay in that category. And that gives us a lot of comfort in saying we can create these long-term enduring relationships between the patients and their PCPs. We also have the ability to look at access in the different geographies and make sure that's appropriate. And we're comfortable that we've done just that. And we've got the conversation that goes into the alignment piece. How can we ensure that the employers are fulfilling their role to give their people the incentive to execute on this strategy? Again, we have very strictly said from a plan design standpoint, you get your best benefit when your care is originated by, is managed by, is guided by your primary care physician. And you get a much lesser or no benefit if you are going out managing your own, self-referring, doing things that have no real connection to having strong clinical guidance. That was a big step for employers who are putting this program in. That is a big change, but is something that we all feel is absolutely necessary to make this model work. At the end of the day, there shouldn't be anyone who sits in a Symposium plan who falls in the, as we've described it in other forums, the medically homeless bucket, those with no PCP relationship. Everyone should be in a strong PCP relationship as part of this program. The other things we have to look at are obviously the total cost of care. As Earl talked about the study, it really is based on normalized cost and therefore is a resource efficiency measure, and that's very important to us. But prices matter too. And so we've spent a lot of time on the Symposium side putting together financial terms with all the systems that we think are market-leading financial terms and make sense relative to the positioning for the employers. And so we've really looked at it from the standpoint of when someone needs care, that's really a combination of utilization and price, and we've got a pretty good sense for where we think that's going to go. As we look at what's happening in this marketplace and just looking at the improved utilization, looking at the impact of having a primary care physician model, having the elements of being able to steer towards high-value specialists as well, those elements in and of themselves, as we look at that relative to Centivo book of business and relative to what we have in this marketplace, say we've got an expectation that we're going to save about 10% of the total medical spend simply by those attributes. Then we look at pricing terms in our different network configurations, and the savings percentage goes up, obviously. Those are relatively important numbers to the provider or to the employer community. They need to be able to find some cost relief relative to their healthcare programs. The interesting thing for employers when they look at the physician value study and see a number like a 40% efficiency improvement by moving people towards the top half, says this is really worth doing, says this is the kind of change that we should be after. So we really are looking at a significant opportunity. We need to take advantage of it. The pieces that go along with that total cost of care review include not just understanding what the total cost of care is when people need care. It obviously picks up the fact that the most cost-efficient possible care is when people don't need care in the first place. So, can we really manage the population? Can we really improve the health status of the covered lives within the group? And if we do that, and if we get the savings that are associated with that, and with the efficiency of care when care is rendered, the savings bucket really should be divvied up between the employers, between the covered lives in the plans, and between the provider community. And that success sharing has to happen to really validate the model. One of the interesting things as we've looked at this marketplace is that in eastern Wisconsin, there are numerous employers that have gone down the path of having their own on-site clinics, on-site primary care clinics, and have really run them in a way that has been well received by their people. And what it really comes down to, and as we talk to the employers who have these in place, they will almost universally come back and say, our people like it, they like the convenience, they like the approach, the way it's been staffed, they like the structure of the care people get, and it really is sort of an effective transactional care kind of setting. It isn't necessarily a great patient manager, holistically, but we haven't necessarily set them up that way, at least at the beginning. And as we evolve them, we may be asking for more. So can we transform from just the sort of occasional interactions with the clinic that a patient may have away from the episodic care perspective towards a holistic patient management? The other thing that employers who have on-sites tell us almost to an employer is that they simply aren't great places for specialty referral. They struggle with where the referral patterns go. A lot of it is controlled by either existing relationships or historical patterns. It is not data informed. One of the things that bringing the GNS data to the table does is start to change that and allow us to have specialty referral patterns that are, in fact, data informed, that really are relying on analytics that help steer towards the higher performing specialists. Something that we are taking advantage of as we work with the on-site clinic providers within this community, whether they be associated with a health system or whether they be an independent provider, and something that creates a new opportunity for us. Ultimate goal of all this is not to live in a world where forevermore we have a stratification process and are cutting off people off the bottom of a list. Instead, the ultimate goal is to make healthcare better in this marketplace. We really do want to bring everybody up into that high-performing bucket. That is something the employers have said consistently throughout this whole process. It is something that from the healthcare provider community, we have asked you very directly to engage in, to make sure that this is a true continuous improvement process. It is something that says, let's address where we are providing less efficient care and move everyone up and really raise eastern Wisconsin to end of the day, an extremely high quality, cost efficient area to get health care. As we talk about what that pathway to improvement looks like, clearly data is a substantial underlying piece of all that. And a piece of data like the physician value study is, from our perspective, invaluable in driving that process forward, in giving good information that is actionable, in being able to get information down to the individual physician level, and give you as a health system provider the ability to do comparative analysis for folks within your group of primary care physicians and for the select specialties that we're talking about, so that you have that information to really be able to make a meaningful difference in the overall care that is being provided. You know, that comes along with multiple stakeholder involvement pieces. It really is a two-way alignment. What we're saying is we're looking to you on the healthcare provider side to raise your game, and the employer side, we're also looking to do the things that are necessary to make that work for you, including elements that we may have in the way we interact with our people. And so it is a dialogue that we're very much engaged in. And again, at the end of the day, a lot of it's going to come back to, from a financial standpoint, the ability to share the success that we are able to create in this model. So the data matters. It is something that is, I think, a incredibly important piece, and the starting point of having the physician value study is really key to that. I'm going to let Dana talk a little bit about sort of the next steps around that and how you can get your hands on some of the data that could be very beneficial in this process. Dana?
Okay, we're getting towards the end. I'm going to talk for just a brief minute about products and services that WIO has available for those of you who are not familiar. I talked earlier about the enhanced data set that we offer, or the ED database. In addition to that, we have another database that's called the Standard Integrated Database. This is really a longitudinal database starting back in January of 2017, all the way up through the current time, really. And we add to that database every quarter in order to update it. This database is predominantly used by researchers or anyone who wants to be able to look at kind of before and after types of analyses. In addition to that, we have created a series of pre-built reports. You access these reports through the web, so you don't have to do any IT work. They're available to both health plans and provider organizations. We have a different set of reports for each stakeholder group. The unique thing about these reports is that when a staff person from either a provider organization or a health plan logs in, it recognizes what organization you work for, and then it renders the data back to you that is specific to your organization in that report. And this is going to become important in just a minute. In addition to that, we do custom work, both creating custom data sets, analytics, and reports. And finally, we do public reporting. The primary publication we use for that is called InfoBytes. All of our InfoBytes are available on our website. If you're interested in getting on our distribution list, please contact me, but this information is free of charge. We take a kind of topic of interest within the state, and then we build some of the data around that. So for example, the one I have on this screen is on telehealth. But I also wanted to introduce to you two new products that will be coming out of WIO in January of 2022. The first is a Medicare fee-for-service data file. So Medicare fee-for-service is about 600 to 700,000 people in the state of Wisconsin. This has been a hole in our data for several years. We were now able to bring the Medicare fee-for-service data in from CMS. We've mapped that data with our other data, and so we have a 2018 data file available that includes Medicare fee-for-service along with all the other data in the WIO database. 2019 will be available sometime in 2022, but as of yet, CMS has not released the 2020 Medicare fee-for-service data. I also want to make you aware of a new reference file, the socioeconomic reference file that we've created. We have brought in data elements out of various public surveys that provide characteristics about the individual members within our database. So things like likely education level, income level, housing density, do they have access to a computer? Those types of data elements. And this reference file will be connected. You can connect it to either the ED or the SID database using a unique de-identified indicator that connects the two data files together. This is really important for the state of Wisconsin to begin to evaluate disparities in care and disparities in health outcomes in the state of Wisconsin. Now I'm going to circle back to reports and what are the important questions to be asking. The first question I always ask when I look at a report is who created the report and why? So in this particular situation, the Business Healthcare Group commissioned the study and they really own the results, but they have asked the WIO to put the results of the study into a report format and to distribute the information to provider organizations only. Within each of the reports, there will be data on primary care and specialty services at the organizational level, and there will also be information at the clinician level for only the provider or organization for which that clinician provides services. In addition, we will be providing an overview of the study methodologies, which you've heard of here today, as well as some benchmarking and other directional information. Finally, only provider organizations that are included in the report, in the study, will have the opportunity to access these reports. There will not be a public report of any of this information outside of what has been presented here today. So these are some mock-ups that I put together. This is not data from this study, so you don't have to focus on the numbers. But I wanted to give you, if you're a provider organization or work for one, give you an idea of what the reports might look like. So you can see at the top, it's kind of small, but it does give an indicator, and each one of the reports does this, of what direction is better for the data. So in this case, higher scores are better. You can also see that there are drop-down lists and there are also scroll bars that allow you to customize what you want to see within each one of the reports. This particular report is a mock-up of quality and cost comparison at the provider organization level. So you will be able to benchmark your results with other provider organizations. This is an example of an individual PCP ranking report. So in this situation, your individual PCPs would be listed where I have MD name 1, 2, and 3. Your individual PCPs would be listed there and you would be able to get information on how each of them has performed in this study individually. Same type of setup for specialist, where we would be providing a report for specialist that compares the outcome of the report at the organizational level. And finally, a similar setup for the individual PCPs within your organization. There are other reports in this reporting suite, but I did want to give you just a quick idea of the type of information that would be available to provider organizations. So what would you do with this information, right? So I think there are a couple of things. You can benchmark your performance against other organizations, and that's critically important because I think we all recognize that provider organizations can't improve everything, right? There's at least 30 different clinical topics that have been evaluated underneath the PCP area, as well as the 10 different specialty procedures. No one can address all of that. So what these reports do is they allow you to determine where should I put my improvement energy, right? Where could I make the best use of the resources that I have? At the individual clinician level, these reports are helpful in a couple of ways. One, you certainly can identify your high-performing clinicians and talk to them and say, well, what are you doing? How are you doing things, right? Create that conversation among a group of specialists, for example. And, you may want to reward some of your high-performing clinicians, and you may want to have conversations with those who perhaps didn't fare quite as well. The information is directional, and it will help you to figure out where do I put my improvement resources. Once you have identified areas where you think you would like to see some improvements, then you can use your existing performance improvement methodologies, processes, et cetera, to identify what are the root causes of the variation that I see among my clinicians, for example. So it's not going to tell you exactly what you're going to have to fix, but I think it will be extremely helpful. So I'm going to stop there, and we'll move to Q&A. Thank you.
Thank you, Dana. So the first question is from an individual who is participating virtually. And Dave, this question is for you. How do you reconcile measuring effectiveness at the individual PCP level but contracting at the system level?
It's a very good question, and it's always good to start with a little tougher one. It's an interesting challenge and not as conflicting as it sort of sounds like it should be. The reality is you can look at contracting models and payment models that try to achieve various results. And I will tell you, you have to recognize that I'm both a consultant and an actuary, which means I can come up with incredibly complex, intellectually fascinating approaches that are wildly unoperational and can't possibly be implemented. So I've tried to stay away from that, and I think we've avoided that in this world. What we've done is said, let's look at how we use that individual physician data to circle back to this model. We want to pay differently. We want to move, especially in the primary care world, away from the majority of payment being on a fee-for-service basis to a payment that really provides both patient management fees and really, over time, continually expands incentive opportunities that are reflective of the actual performance of the individual physicians. And if we do that, then we are creating a contractual opportunity that creates a payment model aligned with the overall approach. We also have the fact that the activation process itself, as people choose their primary care physicians, recognizes that a number of individuals who either don't have an existing PCP relationship or have a less than fully satisfying PCP relationship will be going through a process by which they get recommendations as to the better PCPs they should go to. And by doing that and looking at a recommendation process that steers towards the most efficient PCPs working in systems that have provided the most financially competitive terms, we are going to overweight the amount of service provided by that higher performing physician group. So it really does, from a contracting process and from an operational process, marry those two pieces together.
Okay. The next question is for Dana. And it's really, you effectively just answered this question, but I'll have a follow-up to it. So do you report back results to assist the PCPs that may assist them with improving care paths to be more effective and efficient?
So yes, within the provider reports, you as a provider organization would be able to access the results for your PCPs, whether that's a medical director or a department chair, or maybe the PCPs themselves. Anyone really that we set up could access the data. I think it's really helpful to a physician to get this kind of feedback in a non-threatening way. Quite often, people practice, and I've seen this many times in my work with various organizations on improving their quality and their performance scores. People, have a tendency, because they come to work every day to do a good job, they have a tendency to believe that they're doing a good job and they're doing the best that they can under the circumstances they have. And until you have the opportunity to actually kind of figure out or get some feedback on how you're doing, some of them will be, quite satisfied with how they're doing. There may be others who would begin to ask the questions, well, what are my peers doing differently than what I'm doing? And that's a pretty common dialogue among physicians if they have information to fall back on to start that conversation.
So, and Dana, with the new product offering, when will this new product offering approximately be available to health systems and provider groups?
Yeah, we should be ready by the end of January. We're nearly done with the reports. We've got a little bit more work to do on them. Any organization that wants to access a report should contact me directly. And we will have a little contract for you to sign because I have to keep track of who has access to what. But we're pretty much done with them. So I would say no later than the end of January.
Okay, thank you, Dana. Earl, of the 190 primary care providers identified as high performers, the questioner asked, I'm curious if you've done any analysis to cross-reference that to their patient experience scores?
We did not have access to any patient experience score, so the answer is we did not.
Okay, thank you. We have a question from an individual in the audience.
Yeah, thank you all for the great information today. I think the results are obviously very impressive, and the opportunity for us all is quite staggering as we think about those dollar amounts. I'm curious, we've talked a little bit about Symposium and how they can help the employer community really redirect care for the consumer in a meaningful way. But I want to think about the other ends of the stool, particularly the provider community. How, in your minds, can we really encourage the actionable use of the data that Dana's making available to the provider community?
It's a good question, one that really gets to a number of the operational elements that we as Symposium, in conjunction with the health system partners that we're working with, have, frankly, started on significant numbers of work streams. Part of that is predicated on getting the data, into people's hands and making it actionable in a way that's appropriate. So, for example, using the specialist information and the creation of medical neighborhoods that are, essentially the structure for specialty referrals, and making sure that the technology enablement of that is appropriate. So both having, from the Symposium side, a referral portal that's easy to use, and or working with the health systems that want to be able to embed that into their EMRs, knowing that, anytime you talk about EMRs, you're talking about a tech process within health systems that has both a time and financial expenditure element to it. But it is something that we are very, clearly interested in working with the health systems on. The other piece is making sure that we find ways to share data back and forth. In the ideal world, the health plan is providing back to the provider community all the information on their patients. So if you are the selected PCP of a patient, you should know everything about them that we know. Trying to make that all happen is a significant data flow exchange element that we will continue to work on. As we've talked with a number of the health systems in the area, there is a significant interest in that. There is also a significant work effort that goes along with it. So we from the Symposium side are very committed to making those kind of things happen. Looking forward to the continuing dialogue with the provider community to help. Also making sure that the employer community, frankly, knows how that is happening. And we can come back from the health plan side and give you updates from a measurement perspective to be able to see where things are working and where they're not, and allow us to have that more collaborative dialogue than frankly has happened in the past.
So Dave, I have a question for you. We all benefit from having a financially sustainable healthcare delivery system and good access to healthcare. And you had mentioned in your presentation that, there's a possibility with this process that, some organizations may actually have a reduction in revenue. You also, though, mentioned that, the idea of being able to expand the value of the primary care network is really important to you. Can you share kind of some of the strategies that Centivo's using, either, in other states where you have plans, or you're thinking about using here in Wisconsin that may help to offset any losses that a healthcare organization might have. So for example, are you thinking that over time, maybe you would make larger payments to the primary care provider for the high-value good work that they're doing?
You stole the thunder of one of the comments I probably should have made earlier. As we think about the mix of total expenditures in the healthcare market, and you think about where we are today, about 6 cents on every dollar goes to the primary care community, and that is, from our perspective, wildly too low. We'd love to see that number doubled. And what it really comes back to is a meaningful uptick in the dollars that go into, frankly, the financial resources that PCPs need to really truly manage their patients, as opposed to simply seeing them on a transactional basis. And that is paid for by the downstream savings that go into some of the specialty and tertiary care. Part of that is to really create an incentive structure that feeds back the savings into the stream of dollars that is received by the health systems, ideally, moving back towards the primary care provider specifically. Part of that is making sure that as we look at where the total dollars go, we recognize that this isn't just a zero-sum game. That at the end of the day, as we take care out of areas that frankly are high cost, somewhat inefficient areas for the employer, they're also tending to be things that are some of the most high cost areas for the health systems themselves. If we get substantially less use of emergency rooms, which are by definition expensive places to operate, we can come up with an attractive financial outcome. If we take better advantage of things like virtual care and look at ways to create more efficiency along those lines, if we can help to take better advantage of mid-level practitioners, for example, again, we have taken care to a level which is a very efficient level, a very effective level, and one that has a lower cost price point for the health systems to run. So it is not just taking dollars out of the top line, it's taking dollars out of the expense line as well as we do this, and that does create the financial sustainability.
So Dana, I would like to commend you and WEO on what an incredible asset that WEO is for the state of Wisconsin. And I really don't think that the majority of stakeholders in the state understand how WEO operates differently from all other all-payer databases in other states. And could you provide some insight for those stakeholders, please?
Sure. So WEO was set up in a relatively unique model back in 2005-06 when people started talking about having an all-payer claims database. And it was really set up as a public-private partnership where both the state of Wisconsin as well as private organizations would both use the information, but at the same time would provide, finances to support the operations. We are a not-for-profit, so we're not here to make a lot of money, but as everyone knows, technology is not cheap. And, some of these more sophisticated types of processes, they are not inexpensive. In the vast majority of states, first of all, the APCD is mandated, meaning that the health plans are required to submit their data to the APCD. In Wisconsin, we have an all-voluntary system. So we are extremely grateful to all of the health plans who do participate, as well as Medicaid, as well as the self-funded employers. We actually have as robust a system, about 75–80% of the state, as any state has that has a mandate. So congratulations to Wisconsin for your commitment to providing data that can be shared and used by every stakeholder. The other difference is that in many states, because the state is the kind of the owner and in many states the sole funder of their all-payer claims database, the function of the APCD is exclusively for use by the state and predominantly for policy development. So a lot of the difference in what WEO does is we've actually, because we are a public-private partnership, we've actually had to be a little bit more innovative. So the socioeconomic reference file that I mentioned earlier, I believe we are the only state that has been able to create something like that. I'll be really interested to see what we're able to learn by combining, social and economic characteristics of people in the database with their claims experience. But we simply have to be a little bit more innovative and really think a lot about how can we actually help not just the state of Wisconsin, but private organizations to get value out of the data. And I am always open to people's ideas about that.
Thank you, Dana. So this is the second session today. The first session was with employers and other stakeholders this morning. This session was predominantly with health system and provider group representatives. The next session we have this afternoon is with the broker consultant community and other stakeholders. And then tomorrow we have a final session at the state capitol with legislative representatives and a number of other stakeholders. So with that, I would like to thank once again Dr. Earl Steinberg, Dave, and Dana for your input this afternoon. And also would like to thank all of you who joined us this afternoon. And we truly are looking forward to working with all of you in a collaborative manner to move forward the BHCG GNS physician value study results. So with that, thank you.
Sometimes I feel like I ruined everything. Sometimes I feel like I'm slipping, oh. The way my brain and body reacts to every memory. Sometimes I feel like I'm slipping, oh. I should've listened up when I was young, but I always talk too much. Punch drunk on some bad luck for a time. You gotta make mistakes to know. Takes mistakes to grow, and now I know. Gotta listen up. You gotta listen up. Listen up. When life got real, I didn't know if I could handle it. Too many opinions, I don't wanna listen. But when my brain and body holds listen up.